Now that you've set the scene, I'd like you to tell us what you did and what you found.
The first thing was that we had already our foundations with regards to the service, because we had our VT service, and as I mentioned, we were seeing Ps, but we felt that we needed to do more work with it. So what we did was, the first thing we did was we collectively, as a department, and not just pharmacy, but the entirety of the department, looked at how we managed these outpatient Ps. So I mentioned earlier about risk assessment, and that there is a standardized risk assessment. Well, there are a couple of standardized tools which are used in the UK. One of them is called the PESI score, or the PE severity index, which is probably the most commonly used. And then another one is called the Hestia criteria. And what BTS recommend is that patients who are class 1 or class 2 on the PESI score can usually be considered for ambulatory care. So the first thing was to install that risk assessment modality, so that every patient who was being seen within the SDEC was having that initial risk assessment with the PESI score. There's additional criteria as well, things like whether we were seeing that dreaded right ventricular strain, as I mentioned earlier, on the CT scan, things like biomarkers such as troponins and BNP, and also, as I mentioned earlier, those critical social aspects, and integrating that within our criteria. So we developed our criteria for patients that we felt who presented to the SDEC, who could be managed as ambulatory patients, and which patients would need to be admitted into hospital. The second thing was around the follow-up aspects. Because actually, as I mentioned earlier, it wasn't felt that there was sufficient follow-up for these patients. And I mean that in terms of both short-term follow-up and long-term follow-up. And both of these are critical. So to address the first one, which is short-term follow-up, BTS, as I mentioned earlier, within their quality standards, recommended that all patients with P who are managed as ambulatory patients should be followed up within 7 days of discharge. So what we did, we utilised our pharmacist-led VT service to undertake those 7-day reviews. And what that fundamentally means is bringing the patient back, clinically reviewing them, reviewing their symptoms, reviewing them from the perspective of their observations, listening to their chest, because these patients can be prone to things like chest infections, especially if they've got infarctions. And just making sure that nothing has changed in their clinical status and they remain suitable for ambulatory care. And that's proved extremely useful, which I'll go into later on. But ensuring that they had that 7-day review was critical, but also ensuring that there was that consistency of follow-up long-term. So we've spoken thus far about the patients who are ambulatory patients from day 1, going through the system of day 1, day 7 review, but also not ignoring those patients who weren't suitable for ambulatory care, who ended up being admitted. And what we felt was as well that those patients needed consistency of follow-up as well, because not all these patients were referred to respiratory, and there were various different ways that they were being followed up within the health board. So again, what we developed was that all patients would be initially referred to the VT service. So when patients were discharged, we were on hand to facilitate that discharge, either if they were discharged within 48 hours and seeing them for that 7-day review, or if they were in hospital for longer, ensuring that they were reviewed at around about a month following their diagnosis. And then ensuring that they follow into the standard follow-up pathway then, where they would be followed up for a cause of their VTE, to ensure that they are recovering, to look at things like long-term screening for long-term complications. So some patients, unfortunately, are prone to long-term complications after having a PE. One of them is a condition called CTEPH, or chronic thromboembolic pulmonary hypertension, which is where patients fail to clear the thrombi from their lungs and they develop a pulmonary hypertension. It's an extremely disabling condition. So again, ensuring that these patients had an echo at the 3-month point to screen for that. And also then developing links with our respiratory colleagues, so that if we did have patients where we had concerns about their ongoing symptoms after 3 months, or we felt that their echo showed signs of pulmonary hypertension, they were then referred on to respiratory for further specialist assessment. So the idea is that everybody comes into the system, everybody filters in at some point, and then we get consistency of management across the health board.
So is it fair to say that this is a pathway that ensures that no one falls between the cracks, as it were?
Absolutely. And in fact, our model is slightly unique in terms of the fact that I think if you look across the UK, people would either practice in the acute phase, which would be the front door, or they would focus on the follow-up aspect. I feel that where we've been slightly different is we're doing both. So we have this ideal pathway from day 1 to month 3, but patients will come into that pathway at different points. But the idea is that eventually we reach the same point, and because it's the same group of clinicians doing it, we get that consistency so that every patient referred into the service, it doesn't matter from which point, they will have that input and they'll have that consistency of decision making.